Okay, so today's lecture is going to be on anaphylactic reactions and chest traumas. Here's a quick picture on anaphylactic reactions. It's caused by insect stings like bees, wasps, and ants. It can be caused by medication reactions, food allergies like peanuts, eggs, and shellfish. Here are the signs and symptoms. It's a rapid onset, dyspnea, tight throat. As you can see here, the bee and the medicine pill are choking the patient. Laryngeal edema and bronchospasms. The patient is going to have feelings of apprehension. They're going to have tingling and swelling in the mouth, face, throat, and tongue. They're going to have itching, a decrease in blood pressure, tachycardia, and loss of consciousness. And I want to stress decrease in blood pressure because basically what's happening in the patient is that the blood vessels are vasodilating, and that's going to really help you memorize a lot of the signs and symptoms that I'm going to go into later on. And look, the patient's on this contrast dye because that can cause an anaphylactic reaction, and he's really itchy too. And here's some little looks like some kind of shellfish, because that's one of the food allergies. Okay, let's get into it. Anaphylaxis. You got to focus on the signs and symptoms and the nursing interventions while we're going through this lecture. So keep that in mind. Here's a wonderful video by Michael Linares. He's an RN, and it's a great video that will help introduce you to anaphylaxis. I would recommend it that you watch it. And he also references another video of his videos about MAP, and I would like you to watch that as well, because that has to do with the aneurysm lecture that we're also going to be tested on. So you need to know this anyway, so you might as well watch that video. Here's some nice to know stuff, but not stuff that is the focus of the exam. As you can see, I separated it. This is nice to know, like the patho and stuff like that. And then down here is the stuff that you need to know for the exam. So this is just stuff that I'm exposing you to just in case they throw out some kind of question on that, or they mention something about this in the exam, but it's not really the focus. Because remember, what you as the nurse need to focus on is the signs and symptoms and your interventions as the nurse, okay? But you never know. Some professors just throw these things out there, okay? So just wanted to expose you to this. The patho behind it is some foreign allergen or antigen comes into the body, like the food, the meds, the animal serums, the latex. Then your IgE antibodies freak out and release all these kinds of chemicals like these. And these chemicals cause an excessive vasodilation, and that leads to anaphylaxis, which leads to shock because major organs are not getting enough perfusion. It can be caused by foreign antigens, like I said before, which come in many forms, which I put a chart on right here from the book. I wanted to tell you that antibiotics and contrast dyes cause the most serious reactions, and penicillin is the most common one that you're going to see in the hospital, and it accounts for 75% of fatal reactions per year. Now here's the chart that you can zoom into and read up on if you would like. Prevention: basically avoid the allergens. Carry an EpiPen. It delivers a pre-measured dose of 0.3 milligrams or 0.15 milligrams. Immunotherapy can reduce anaphylaxis it can reduce the reaction, your reaction to these allergens, okay? Like with the insect stings. But remember that immunotherapy is not going to be a cure. It's going to help reduce your reaction, but it's not going to cure you. You're still going to be allergic to, say, bee stings. If you got diabetes and you're allergic to insulin, or you're allergic to penicillin, which is one of the most widely used antibiotics to treat infections, then we can start to slowly desensitize the patient to the medication so that they could use it, because a diabetic needs their insulin. They can't just go without their insulin. However, you got to warn the patients that if they don't take their medications, then the allergic reactions are going to reappear when they start taking them again. So that diabetic patient, if he stops taking his insulin, not only is his blood sugar going to go up, but also he's going to lose any desensitization that he has received over the course of his medication regimen. And then when he suddenly decides to start getting back on that regimen, he could go into anaphylactic shock. So again, remember, this is not a cure. Medical management. Epinephrine is going to be in a 1 to 1000 dilution, and it's administered sub-Q in the upper extremity or the thigh. It may be followed by a continuous IV infusion, and antihistamines and corticosteroids may also be administered to prevent reoccurrences and to treat other problems. It basically, we're bringing up your blood pressure with these interventions like IV fluids, volume expanders, and vasopressors. Because again, anaphylactic shock is basically your blood vessels dilating and your organs, your major organs, aren't getting enough perfusion. So we're going to try to bring that blood pressure up by giving them fluids or constricting the blood vessels again. If the patient has a history of bronchospasms, bronchial asthma, or COPD, then we can add these drugs into the regimen, like aminophylline, corticosteroids, things like that, because we want to increase the airway patency and function. Patients that have experienced anaphylactic reactions and received epinephrine should be transported to the ER for observation and monitoring. You may ask why. Well, there's a risk here for a rebound or a delayed reaction 4 to 10 hours after the initial allergic reaction. So the patient could very well have applied the EpiPen and felt much better. However, they still need to go to the emergency room so that they can be monitored in case they have that rebound reaction. Patients with severe reactions are monitored closely for 12 to 14 hours in a facility that can provide emergency care if needed because of the reasons I mentioned earlier. Because of the potential for reoccurrence, patients with even mild reactions must be informed about this risk. Okay, now we're moving on to the stuff that you really need to know and focus on for this exam and as a nurse in general. And here's the learning objective. Determine the clinical manifestations and nursing management of a patient with anaphylaxis. Clinical manifestations. They can range from mild to severe. The faster the onset, the more severe the reaction. The severity of previous reactions does not determine the severity of subsequent reactions. So they could very well have had a mild reaction to, say, a bee sting 5 years ago, but that doesn't mean they're not going to go into anaphylactic shock if they get stung by a bee again. So take that into consideration. Now, let's go into the clinical manifestations for mild reactions. They could have peripheral tingling, warmth, a sensation of fullness in the mouth and throat, and that's due to the swelling that's starting up right there. Nasal congestion, swollen eyes, itching, which is also known as pruritus, sneezing, and tearing of the eyes. For mild reactions, the symptoms begin within the first 2 hours after exposure. Now let's move on to moderate systemic reactions. They could get flushing warmth, anxiety, itching, plus everything that we said in the mild symptoms section. More serious reactions include bronchospasms and edema of the airway or larynx with dyspnea, cough, and wheezing. Again, the onset is usually 2 hours after exposure. Now let's go into the severe systemic reactions. With severe reactions, you're going to have an abrupt onset. So just to compare the two, remember in mild and moderate and slightly more moderate, you would have symptoms occurring after the first 2 hours. But so with severe, or actually within the first 2 hours. So the symptoms, you could have gone to a shellfish buffet and this guy's allergic to shellfish, and if he's having a mild or moderate or slightly more moderate reaction, then it's the signs and symptoms may not appear for like an hour after he leaves the buffet, or an hour and a half, or something like that. But with severe reactions, this guy's going to have a reaction immediately. It's going to be abrupt. And you're going to have the same signs and symptoms described above, except that they're happening fast, quickly. They're going to rapidly progress to bronchospasms, laryngeal edema, severe dyspnea, cyanosis, and hypoventilation and hypotension. The patient can also have dysphagia, difficulty swallowing, abdominal cramping, vomiting, diarrhea, and seizures. Okay, because the body's trying to excrete that allergen. And cardiac arrest and coma may follow. So if they go into cardiac arrest, you need to perform CPR immediately. So you wouldn't just start asking questions or anything like that. In this case, you would immediately start your intervention. Nursing management. If you have time for these things, you would assess the patient first. You would check the airway, the breathing, the vital signs. You would watch for signs of edema or respiratory distress. If you notice that they're having a severe reaction, then you're going to call the rapid response team or the provider so that they can go ahead and start that CPR. And they're going to basically start emergency measures. They're going to intubate the patient. They're going to administer emergency meds. They're going to insert an IV line, or actually, you should be inserting the IV line if possible. And fluid administration is going to start because, like I said, the biggest problem with anaphylactic shock is that the blood vessels have dilated too much, and thus the vital organs like the brain and the heart aren't receiving enough perfusion. So you're going to want to increase the fluids inside of the blood vessels to increase the blood pressure and hopefully increase the perfusion. And you're going to administer oxygen as well for the very same reason, to increase the perfusion. Okay? This is going to reduce the severity of the reaction and restore cardiovascular function. And then after all of this, the nurse, as the nurse, you're going to document all the interventions that you used and the patient's vital signs in response to your treatment. In the recovery phase, the patient is going to want an explanation of what occurred. So you're going to give that to him. And you're going to give them instructions about avoiding future exposure to antigens. So that patient we explained about earlier that went to that shellfish buffet knowing that he has a shellfish allergy, he's not going to go to that shellfish buffet any longer. And you're going to teach him how to administer emergency medications to treat anaphylaxis. You're going to teach him about what he should avoid. You're going to teach him how to prevent reoccurrence. You're going to give him, this patient should receive a prescription of an EpiPen. And the nurse is going to teach the patient how to use the EpiPen. Now let's go into patient teaching. The EpiPen. Here's a nice video that will teach you how to use an EpiPen. Basically, blue to the sky, orange to the thigh. Okay? That's basically what I want you to remember. So here's a more in-depth explanation of the EpiPen administration that I got from the book. You're gonna basically grasp it in your hand. You're gonna put the orange tip, the injection, and pointing. You're gonna point that downwards. You're gonna remove the blue safety release cap, as you can see here, the blue to the sky, orange to the thigh. And then you're going to jab your thigh with it at a 90-degree angle, and don't inject your butt, okay? So really show that patient, yeah, this is your thigh, this is your butt. Do not inject the butt, inject the thigh, okay? And you're going to hold that EpiPen against your thigh for 10 seconds. And then you're going to remove it from the thigh, and you're going to massage the injection area for 10 seconds again. And that's just to help the medication get absorbed more quickly, because remember, this is an emergency. And then after that, you're going to call 911 and seek immediate medical care, because again, they can have a rebound. They can have a rebound of their anaphylactic shock, okay? So they need to be monitored for that and treated for that in case it happens. And then also, they're going to take that EpiPen with them to the ER, okay? So remind them of that. And that's everything you need to know for anaphylaxis. Now let's move on to chest traumas. And this lecture is going to include the sternal and rib fractures, the flail chest, and pulmonary contusions, which is just the fancy term for saying a bruised lung, okay? So with regards to this exemplar, you need to know these things, these subcategories of a chest trauma. Now let's talk about chest traumas in general. They're often life-threatening, and they have several causes, and the most common ones are car accidents, falls, and bike crashes. The reason car accidents can cause a chest trauma is because of the wheel hitting your chest, or the seat belt. The impact of the accident could make you hurt yourself with the seat belt. With regards to bike crashes, well, the handlebars can crash into your chest. And here's a picture of a lady who just got her chest slammed into her driving wheel. Okay, she's probably gonna suffer from a chest trauma. In this patient, you can clearly see the outline of the seat belt. So yeah, that car accident caused this, and that could cause a chest trauma. Well, it will cause a chest trauma. These are the different types. There could be the different types of problems that can occur with a chest trauma. You can have a fracture or dislocation, all kinds of injuries like a diaphragm injury, injury of the pleura, the lungs, the aerodigestive tracts. You can hurt your heart, your arteries, your veins, and your lymphatic system. And basically, when you hurt these things, they can lead to hypoxemia, hypovolemia, and cardiac failure. And this goes into a description of it. But basically, what I want you to take from it is it's going to cause hypoxemia, hypovolemia, and cardiac failure. Okay? And this is just like the different causes of it. Like, what could cause hypoxemia after a chest trauma? Okay, well, maybe you disrupted the airway. Maybe you hurt your lung. Maybe you hurt your rib cage. Maybe you're hemorrhaging. Maybe you got a collapsed lung. Maybe you got a pneumothorax. And for hypovolemia, maybe you're losing lots of fluids. Maybe your heart got ruptured. Maybe you got blood filling up your thorax. With cardiac failure, you can have a cardiac tamponade, which is basically the heart is drowning in its own fluids, in its own blood. And that like keeps it, the pressure of the fluids is keeping it from beating, okay? You can have a cardiac contusion, which is just a fancy term for a bruised heart. Or you can have increased intrathoracic pressure. Your heart is getting squeezed to death. So these pathologic states frequently result in impaired ventilation and perfusion, which can lead to acute renal failure. And this is important because any drugs that we give this patient to help with the chest trauma, with the injury, is not going to be able to get excreted if your kidneys aren't working, if you're in acute kidney failure. You can also go into hypovolemic shock and you could die. All right. Assessment. Time is of the essence. Assess as soon as possible. These injuries are life-threatening and require immediate treatment, okay? So whenever you have a patient that got into a car accident and he suffered a chest trauma, like he rammed his chest against the wheel or anything like that, then you need to, this patient's most likely going to come to the ER and you need to assess this patient fast, okay? Really fast, because these people can die really quickly, okay? In fact, some people um, are dead on arrival. So yeah, as soon as possible, try to get to these patients and assess them so that we can do the appropriate interventions for them. Okay, so the subjective data, if the patient is conscious, you have to figure out how much time has passed since the injury occurred. You figure out the mechanism of the injury. Did they hit their chest on the wheel, or did they hurt themselves on the seat belt, anything like that? Level of responsiveness, um, the specific injuries that they have, how much blood they've lost, any recent drug or alcohol use, and what the pre-hospital treatment was. You can probably get that from the EMTs that come in and that bring the patient in. Here's the objective data. The first assessment is basically you looking for anything that will kill the patient right now, like an airway obstruction, a tension pneumothorax, and this is basically what a tension pneumothorax is. We can zoom in right here. This is a tension pneumothorax. Air basically enters the pleural space and compresses the lung and shifts the mediastinum. This is the medium stinum where the heart is, the middle. Okay, so air is coming through this wound. If you assess them, you're gonna have hyperresonance, which basically sounds like you're tapping on a little drum, and you're gonna have decreased breath sounds on the affected area. And it's usually treated with a needle decompression in the second intercostal space at the midclavicular line, followed by a tube thoracostomy. And this little lung is like, is the tube in yet? Because he is stressed out because he's under a lot of tension. See, this guy is getting squeezed over here to the right side. And look, you could even have a tracheal deviation. So if you see the patient's throat, the trachea could have been moved to the side. Okay, and an airway obstruction is kind of self-explanatory. If there's an airway obstruction, the patient can't breathe, and thus they could die immediately. So you want to fix that as soon as possible. And an open pneumothorax would be an emergency too, and you can watch this video on that. Massive hemothorax would be an emergency, and that's basically where a ton of blood goes into the thoracic cavity. And a flail chest would be an emergency as well, because it could nick the other organs, major organs, like if it's in the lower region, then it could nick the spleen or the liver or anything like that. A cardiac tamponade would also be an emergency because lots of fluid is in the pericardial space and thus the heart can't beat properly. Because when you think about it, the heart needs to contract and expand, right? Well, it can't expand if it's being squeezed to death by all that fluid. And here you can see this little picture of a cardiac tamponade. And a sign or symptom of that would be distended neck veins, okay, because the blood is getting backed up there, okay? And there's an accumulation of fluid in the pericardial sac, which impairs diastolic filling and reduces cardiac output, okay? And he's like, next, Priard. And this guy is basically saying, I think he meant Beck's triad. And you could have hypotension and muffled heart sounds, which is why you couldn't hear what he was saying in this picture. Okay, cardiac tamponade, Beck's triad. Basically, the three things that you need to watch out for with regards to a cardiac tamponade are distended neck veins, jugular venous distension, JVD, muffled or distant heart sounds. See? As you can see here, crush, crush, squeeze, squeeze, constrict, constrict, decreased diastolic filling, decreased diastolic filling, tamponade, tamponade. Okay. And the third thing is low blood pressure. Okay, as we could have seen like here as well, hypotension. The heart isn't able to pump blood effectively, which is decreasing the blood pressure. And you can't hear it really well because it isn't beating properly because of all that pressure on it. And here's another visual of what it looks like. See, it's filling the pericardial sac, and basically now it's completely full, and the heart is going to have really a lot of difficulty with contracting and relaxing and really filling, and thus that will lead to hypotension. All right, now let's look into your second assessment. When you receive this patient, he's been in a car accident, you've assessed, done the first assessment, okay, he's not in any immediate trouble. What's the second assessment that you're going to do? Okay, you're going to look for things that may kill the patient later on, like a simple pneumothorax, a hemothorax, which is basically just blood in the thorax, a pulmonary contusion, which is a lung bruising, which we're going to talk about later on, a traumatic aortic rupture, a tracheobronchial disruption, um, and an esophageal perforation, a traumatic diaphragmatic injury. The diaphragm is basically injured, or penetrated trading wounds to the mediastinum. Okay, so they have something penetrating the middle of their chest. The physical examination includes inspection of the airway, the thorax, the neck veins, and breathing difficulty. With regards to neck veins, that's basically a sign or symptom of cardiac tamponade, which is why you're looking at those neck veins, because they're going to show if the heart is having some if the blood is getting backed up right there, which would be an indicator for a cardiac tamponade. And here's a Nursing 121 review. And I basically just want you to skim the stuff in italics because it's stuff you already learned, or it's common sense stuff. But I just wanted to expose this to you just in case, because it was mentioned in the book. So basically, you do a complete respiratory assessment on these patients, which includes the respiratory basic stuff, and with the addition of obvious injuries, like basically if they have a tube sticking out of their chest, you would like to know about that. You would like to let the doctor know about that. Or you would like to jot that down. Hey, this person has a giant tube in his chest. Okay, so I kind of don't want to go through all this because it's obviously 121 stuff, with the addition of the major stuff that you would want the doctor to know about, like a huge stick coming out of his chest, or burns, lacerations, things like that, okay? Along with all the, 121 respiratory assessment stuff like cyanosis, nasal flaring. Those all are indicators of respiratory distress, okay? Use of accessory muscles. Okay, and obviously the thorax is palpated for tenderness and crepitus. And crepitus would mean there's air in there. Tenderness means that something's injured. Okay, the position of the trachea is also assessed because, again, like I said, when there's a lot of air going inside of the chest, as we saw here in this picture, here, in a tension pneumothorax, the trachea could be moved to the side. Okay, so that's why you assess the trachea for trachea deviations, because that could be a sign of a tension pneumothorax, which would be one of the priority things that are going to kill you right now. Okay, so that's something important to take note of. Okay, diagnostic findings. This is basically the same stuff that we talked about earlier in the general chest stuff that we talked about, which is right over here, I think somewhere around here. Basically, okay, let's just go over it. So we won't have to go over it ever again, because this is going to be repeated over and over and over again, okay? Which is why I put it in italics. It's just getting repeated over and over again in all the different conditions. Okay, so it's the diagnostic things that the diagnostics that are going to be performed are the chest x-rays, the CT scans, the CBCs, the clotting studies, type and cross-match, electrolytes, O2 stat, ABGs, and ECGs. Basically everything to check how they're breathing and what's going on with their chest. And when you're doing an assessment, you're going to completely undress this patient to avoid missing any additional injuries that may complicate the care. So basically, as soon as they come into the ER with traumatic chest injury, you're going to strip them down and see all of their business, okay? You're going to see everything and check for everything, because you don't want to miss some kind of huge tube sticking out of somewhere just because you were being too shy and didn't want to strip the patient. So really get in there and, strip them down. Medical management. Initiate aggressive resuscitation, O2 support, and endotracheal intubation and ventilatory support. Because remember, these people are sometimes dead on arrival, and you don't want them to die on you. These are life-threatening problems, and you want to, treat this aggressively. You're going to reestablish fluid volume and negative intrapleural pressure. That just means you're going to keep the lung expanded, and you're going to drain any fluid or blood that's in there that's keeping the lungs from expanding, or that's putting pressure on the heart, as we could see in the cardiac tamponade that we discussed earlier. Usually, there's lots of blood loss after a chest trauma, and many patients die at the scene or are in shock by the time that help arrives. So by the time the EMTs arrive, they could be already dead on arrival, which is why I put this picture, TOA. Agitation and irrational and combative behavior are signs of low O2 in the cerebral cortex, and I want you to remember this, because this is repeated over and over again in several of the other subcategories of chest traumas, and also in other conditions as well. Whenever you see agitation or irrational or combative behavior, that's usually a sign that O2 is low for the brain. Okay, so you're going to restore and maintain cardiopulmonary function by ensuring adequate airway and ventilation. You're going to stabilize and reestablish the chest wall integrity. So if they have a giant gaping hole right there, you're going to try to cover that up, because that's ruining the negative pressure that usually keeps the lungs expanded. You're going to occlude any opening in the chest, like in an open pneumothorax. That's basically what I just said. And you're going to take out any of the crap that's in the thorax, like the blood, the pus, the fluids, the water, whatever. And that's to relieve the pneumothorax, the hemothorax, or the cardiac tamponade. Hypovolemia and low cardiac output must be corrected. Okay, many of these treatment efforts are carried out simultaneously at the scene of the injury, or in the ER. See, look, all these people are doing all these things at the same time. CPR, putting on these monitors, and giving them some respiratory support. Depending on the success of these efforts to control the hemorrhage in the ER, the patient may be taken immediately to the OR. Look at these nurses rushing to the OR. Okay, now let's go into the subcategories of the chest trauma that I said we were going to go into. See, we're going to start with sternal and rib fractures, then we're going to go into flail chest, and then we're going to go into pulmonary contusion, which is basically a bruised lung. Okay, with regards to sternal and rib fractures, the most commonly they occur because of a car accident or a direct blow to the sternum via the steering wheel. And rib fractures are the most common type of chest trauma. They make up more than 50% of the patients that we received. And most rib fractures are benign and they're treated conservatively. Ribs 4 to 10 are most frequently involved, and the lower rib fractures injure the spleen and the liver, commonly injure the spleen and the liver. And basically, they're injured because they're being cut by fragmented sections of the rib. See, here's ribs 4 through 10, and here's where the spleen and liver are, and they're in the lower ribs. So if these lower ribs get broken, they're most likely going to nick you, or scratch or cut your spleen or your liver. Fractures of the first 3 ribs are rare, but can result in a high mortality rate because they are associated with cuts on your subclavian artery or vein, which is these blood vessels right here that lead into your arm. So it's basically going to lead to the same amount of bleeding that you would get if you had your arm chopped off, which, as you can imagine, would be a lot. So that's why they are associated with a high mortality rate. Older adult patients with 3 or more rib fractures have been shown to have 5 times the increased mortality rate and 4 times the incidence of pneumonia. Clinical manifestations, common sense stuff. Basically, if they have a sternal fracture, the front of the chest is going to hurt and they're going to have overlying tenderness. And then all the other obvious signs and symptoms. If they have a rib fracture, then they're going to have point tenderness and muscle spasms, as well as the other obvious signs and symptoms. And the area around the fracture may be bruised. They're going to have pain. Okay, blah, blah, blah. That's obvious stuff, okay? It's going to result in respiratory insufficiency and respiratory failure because they're reluctant to move or breathe because it hurts to breathe. So the reasons it could hurt is because of this, because of that, or because of this. Actually, because they have broken bones, basically. And this was just what it could result in. And it can also result in this, which would be the worst. Okay. All right. Okay. So your assessment. You're going to assess the patient and you're going to hear some crackling and some grating sounds in the thorax, which is called subcutaneous crepitus. And that's noticed on auscultation. So you're going to be auscultating them and you're going to be hearing these sounds. Diagnostic findings. I put these in italics because they're the same as before. Chest x-rays, ECGs, pulse ox, ABGs. Medical management. They're obvious. You're going to relieve the pain. You're going to avoid them from moving too much because they have broken bones. And you're going to treat any associated injuries. Surgical fixation is rarely necessary unless the fragments are so grossly displaced and they pose a potential for further injury. The goals of treatment for rib fractures are to control pain. Okay, I put these into italics because they're obvious. You're going to control pain by sedating them, and that's going to help allow them to deep breathe and cough and blah, blah, blah. Alternate pain strategies, nerve blocks, ice. Okay. Another another thing that you can use is chest binding, because that supports the chest. And it provides stability to the chest wall, and it helps decrease pain. And you're going to instruct the patient to apply it snugly, but not so snug that they can't breathe. And usually, with regards to broken bones in the chest, the pain goes down in 5 to 7 days, and the discomfort can be relieved by drugs, basically. And most of the broken bones can be healed in 3 to 6 weeks. So around a month, or a little more than a month. More or less a month, basically. The patient is monitored closely for signs and symptoms of associated injuries. All right, and that's basically the end of the broken bones section of chest trauma. Now we're going to move into flail chest. This is what it looks like. Follow this YouTube link to watch various patients with a flail chest so that you can get exposed to it and be able to identify it in the hospital setting. The most common cause of a flail chest is a steering wheel injury. It's basically you get a flail chest when 3 or more ribs are fractured and at 2 or more sites, resulting in free-floating rib segments. And here's a visual on that. 3 ribs are broken, and that's resulting in a flail chest. And it may also result as a combo fracture of ribs and costal cartilages / the sternum. So maybe it's not just the bones that are messed up. Maybe it's the cartilage or the sternum as well. And this is going to cause respiratory impairment and severe respiratory distress because they can't breathe properly. And here's the patho behind it. And this is kind of, common sense stuff, but let's go into it. So basically when they're inhaling, it's going to pop out. Let's see. Okay, when they're inhaling, it's going to go inward. And when they're exhaling, then it's going to bulge outwards. But basically what I want you to grab from this is that as they're inhaling and exhaling, the heart is going to be getting pushed around. It's going to get pushed to this side, it's going to get pushed to that side, and that's going to cause some cardiac problems, okay? So inhale. See, this heart is getting pushed to this side, and as they exhale, the heart is getting pushed to this side in this picture, as you can see here. And that's going to result in increased dead space, a reduction in alveolar ventilation, and decreased compliance. Basically, they're not going to be able to breathe properly. And it's frequently accompanied by retained airway secretions and atelectasis, which is another word for lung collapse. And the patient's going to be hypoxemic, and they may have respiratory acidosis. It's often followed by hypotension, and that's in relationship to the heart being pushed around. Inadequate tissue perfusion, again, the heart is being pushed around, and obviously that's not the paradox between the lung movements is going to cause impairments with the perfusion. The air is not going to be getting perfused to the blood vessels. And it's also going to cause metabolic acidosis. And here I just mentioned that again, that, I wanted you to remember that as with a flail chest, the heart is getting pushed around, okay? And that's going to cause decreased cardiac output. Medical management. It's similar to a rib fracture, and it includes providing ventilatory support, clearing the secretions, and controlling pain. If it's a small segment of the chest involved, then the objectives are to clear the airway through these obvious methods like positioning, coughing, deep breathing, and suctioning, and relieving the pain through these drugs. For mild to moderate flail chest injuries, the underlying pulmonary contusion is treated by monitoring fluid intake, appropriate fluid replacement, relieving chest pain, and monitoring the patient. For severe flail chest, we're just going to have to put an endotracheal tube in there, okay? We're just going to have to trach these people. We're going to put them on an endotracheal intubation and a mechanical ventilation, because it's so severe that they can't breathe properly. It's gotten to the point where they're not getting any perfusion at all. So we need to breathe for them until the issue gets fixed. And this helps to treat the underlying pulmonary contusion, stabilizes the thoracic cage to allow for the fracture to heal, and it improves the ventilation and the intrathoracic volume, and it decreases the work of breathing, which helps promote healing. In rare circumstances, surgery may be required to quickly stabilize the filled segment. As you can see here, they've stabilized the segment. This may be used for patients who are difficult to ventilate, or high-risk patients with underlying lung disease, because they might be difficult to wean from a mechanical ventilator. And this is just a little snippet of information. Recent evidence finds that internal rib fixation may shorten the time required for mechanical ventilation. And this is an internal rib fixation. Basically anything that fixes the rib cage in place when it's broken. It's usually like little metal things or some kind of splint of some kind that's put right there. And I put this in italics because it's basically the same things that we already mentioned. You're going to be monitoring the chest x-rays, ABGs, pulse ox, and pulmonary function tests. You're going to be managing their pain through all these medications. And that's it for flail chest. Now we're going to move on to pulmonary contusion, aka a bruised lung. It's frequently associated with a flail chest, so if you got hurt so bad that 3 or more of your ribs got broken, then most likely your lung got bruised in the process as well, which is why they're associated with one another. Definition. Basically, you have a bruised lung. There's damage to the lung tissues, and that results in bleeding and edema. Cause. The cause is rapid compression and decompression to the chest wall. Basically, you get hit in the chest. Characterized by crap in the lungs, like fluid, blood, etc., etc. Various degrees of respiratory dysfunction and sometimes respiratory failure. The most common, potentially life-threatening chest injury. Its mortality is often attributed to other associated injuries, so it's this pretty bad, okay? So when you get hit so bad that a lot of your ribs got broken and your lung got bruised, then, that's life-threatening, okay? Pulmonary contusion may not be evident initially on examination, but develops in the post-traumatic period. It may involve anything as little as a little section of the lung, or it can involve both lungs, so both lungs could be bruised up and bleeding out. Depending on the extent of the injury, this type of trauma may be associated with a mortality rate of greater than 50%. Here's some patho behind it. Basically, the bruise causes abnormal accumulation of fluid in the lungs, and this is how it happens. You get hurt, serum protein and plasma leaks in, pulls fluid from the capillaries, and all this crap goes inside the lungs, like blood, edema, and cellular debris. It accumulates over time, and then it gets to the point where it interferes with gas exchange, and then that also increases the resistance on your vascular system, and pulmonary artery pressure occurs. So there's pressure on your arteries as well. And the patient has hypoxemia as a result of all of this and their CO2 retention. Occasionally, a bruised lung occurs on the other side of the point of body impact, and this is known as a counter-coup contusion. This is just a term that I wanted you to get familiar with in case they throw that out there on the exam. Okay, clinical manifestations. Pulmonary contusion may be mild, moderate, or severe. In mild, you're going to have decreased breath sounds, tachypnea, tachycardia, chest pain, hypoxia, and blood-tinged secretions. And all these are going to be in the mild form of them. So you're going to have mild tachypnea, mild tachycardia, etc., etc. In moderate pulmonary contusions, you're going to have a large amount of mucus, a large amount of serum, a large amount of blood inside of your chest, okay? And the patient's going to have a constant cough, but they're not going to be able to clear their secretions. They're not going to be able to clear all the crap that's in their lungs. In severe lung bruise, you're going to have severe tachypnea, severe tachycardia. You're going to have crackles, frank bleeding. You're going to have severe hypoxemia to the point where you're actually seeing central cyanosis in the patient. You're going to have respiratory acidosis when you take out those ABGs in the diagnostic studies that I mentioned earlier. You're going to have agitation because the brain isn't getting enough perfusion, and whenever the brain doesn't get enough perfusion, it gets angry, okay? Because the cerebral cortex controls your emotions and your behavior. So, as I said earlier, the brain's not getting enough oxygen, so they're going to have combativeness, okay? They're going to have a productive cough with frothy, bloody secretions. And here's some assessment. As I said earlier, this is just repetitive stuff that just continues throughout all of the chest trauma subcategories. You're going to have to take ABGs, the pulse ox. You're going to be monitoring the pulse ox, to measure the O2 stats continuously. And with regards to diagnostic findings, the initial chest x-ray may show no changes. So initially, when they come in with a bruised lung, you might not see any changes until later on, like 1 to 2 days later, when the fluid starts to accumulate in the lungs, okay, in the form of blood or fluids, whatever. And that's going to appear as pulmonary infiltrates in the chest x-ray. And pulmonary infiltrates are basically a substance that's denser than air, such as pus, blood, or protein. And they look white on the x-rays. And here's a picture of that. Medical management. Basically, repetitive stuff that we've mentioned already, like controlling pain, providing oxygenation, and maintaining that airway. In the mild form, you're going to focus on adequate hydration via IV fluids, oral intake, and you're going to mobilize those secretions, because stagnant water is a perfect, medium for bacterial growth. So you want to be moving the patient around. You're going to closely monitor them to avoid hypervolemia, and you're going to remove the secretions via volume expansion techniques or postural drainage, and physiotherapy like coughing, encouraging the patient to cough, or you can do some endotracheal suctioning. And then here's the repetitive stuff that is repeatedly mentioned throughout chest traumas, which is basically you manage their pain. You can manage it through all these drugs right here. Okay. And also, you're going to do give them some antimicrobial therapy prophylactically, because a damaged lung is susceptible to infection, because it gets fluid accumulates inside of it, and stagnant water, it's going to eventually start to grow bacteria in there. Okay? So, stagnant water equals bacteria growth, which equals bad, which is why we are giving them these antimicrobial therapies prophylactically. Okay, so every time they breathe in, they're introducing, microbes in there, and they're like, oh, look, there's this big stagnant pool of water or fluids or blood or whatever. Oh, that's so high in nutrients too. Ooh, let me go in there. And they're going to start multiplying and having a fiesta in there. And you don't want that to happen. So that's why we do antimicrobial therapy. And that's also why we move the patient around as well, because we don't want that stagnant water in the lungs, because it's going to be a perfect medium for bacterial growth. Okay, so you're going to also give them supplemental O2 by mask or nasal cannula for the first day or so, basically. So for the first 24 to 36 hours. In a moderate case of lung bruising, you're going to have a bronchoscopy to remove the secretions. They're going to be intubated. They're going to be on a mechanical ventilation with a PEEP. And they're going to be getting an NG tube inserted to relieve the GI distension. In severe cases, we're going to aggressively treat this with an endotracheal intubation. We're going to give them some ventilatory support. We're going to give them some diuretics to release all that fluid in their lungs. And we're going to put them on fluid restriction if necessary. And of course, we're going to follow up with that antimicrobial medication prophylactically, because this is a common complication of pulmonary contusions, basically lung bruising, especially pneumonia in the bruised segment, because the stagnant fluid and blood in the lungs serve as an excellent medium for bacterial growth, as I mentioned earlier. And this ends my lecture.